Assalamu alaikum. I would say good morning, late morning. My name is Abdulelah Murshid. I'm an adult cardiac surgeon, and I'm attending this meeting on behalf of myself. And I would like to thank the organizing committee, Dr. Fawaz, to allow me to share this subject with you and share my patient experience in this subject. This was an added discussion to the debate of yesterday about the best modality for treatment of post-MI VSD. And I thought, or they thought, the best testimony should come from the other team members or from the enemy to say which way to go. That's why it was delayed to today. It was better to be at that time. Okay, so I will start without delay. I have no disclosure to any device company. And in this lecture, I will try to show how surgical repair of post-myocardial VSD is complex, difficult, and the period care is really critical. And I will try to show where the surgeons and interventional cardiologists stands in front of this pathology now. And hopefully I could convince the interventional cardiologists to try to harder to take over part of the treatment in this pathology. These are the famous statistics of post-MI VSD. The occurrence in the reperfusion era is about 0.5%, and the mortality is 90% with medical treatment. With surgery, about 43 to 47% you lose these patients, and only near half of them live for the next 5 years. It's ugly statistics. Now, the evidence for advising specific treatment for VSD, it remains in the literature observational and retrospective. There is no randomized trials for ethical reasons, obviously, and the sample is always small. The biggest series in the literature is 50 patients for the comparison, the most, the last ones. And most series between 11, 12, 30. There is nothing more than 57 patients in each series. And so the sample is always small, and there is a major selection base, and I'll explain this in the last line of this slide, why there is a selection base. Now, recently, in the last 5 years, we start to see retrospective analysis comparing both technique, transcatheter and surgical repair. And the last thing, why there is a selection bay. Now, this selection bay means that for patients who are inoperable or hemodynamically unstable, or they have established multi-system failure, these patients, we give them watch period, but it's in real life. This is a declaration of survival. You're going to take the survivor to operate or to do transcutaneous. So this segment of patient is missing from any mode of treatment. They die. So that's make the base in our data. Just few pathologic highlights I would like to mention. The defect is a 3D structure. It's not just simple hole. Classically, it's apical, anterior, and basal. And see, look how it looks. This is a 3D printing of a septum of autopsy patient had. It shows you how it is eaten away. And believe it, it's changed the size during systole and diastole. And in the literature, the small is defined between 8 and 14 millimeter, while the large between 12 and 18. And this is significant if you want to talk about devices. It's either a communication or comes with the bad one, the serpengus type, the one like a bunker with a small hole, and then there is a tunnel below. This is the worst thing because the whole thing disintegrates when you stitch. The rim. Surgeons, they have a big issue with the rim there. These are fresh, from my patients, fresh MI VSD. See how the rim is thin, less than a week, friable, and it is jagged. It's largely made by liquefied myoglobin, necrosed. Compared when it is more than 2 weeks, it is firm, thick, and rounded, and you start to see collagen, fibers, hair where the suture hold. Hair, it just breaks. Surgeon always they have a homework to deal with these cases. Sometimes this becomes a nightmare for us. We have to decide until the cardiologist and the family when we're gonna operate. And we have to see the patients 2-3 times a day just until we pass through the survival period, and we offer maximum support we can just to keep him alive, to get more time for the tissue to mature. And then we have to decide to revascularize how, before, after, and the logistics in ICU and in surgery. And then the last thing, we have to handle the family, why we are not operating yet, and the mortality and those issues. I will share with you how we decide about these cases. We stratify patients. We are called to see them, and when we see these, and this is based on what we see in the patient file, and we do our history and physical. And we classify into 3 categories. The one with the normal hemodynamics and systemic system function. Here we can wait and push for surgery later. Then comes the one with the mild dysfunction, or blood pressure is 90s. So we offer multi-system support and give them 24 to 48 hours and see how they evolve. Improve, we push for more time and delay until at least we hit 10 days to 2 weeks. The bad ones are the one with established multi-organ failure or cardiogenic shock. This one, everybody offer the maximum hemodynamic support, balloons, ECMO, Abdulelah together. If they improve, we operate by the 17 days. We don't push our luck more than that. If they deteriorate, we call back again the heart team, and we talk again to the family and tell them we're gonna operate, but prepare for condolences, because these patients, they don't make it easily. I'll just share with you my last, my few 6 cases. This is a single surgeon. This 5 minutes.
Can you, how much time do you need?
I need another 5 minutes.
Can you 5 minutes?
Okay, okay. These are my case series. Is only 6 cases. It's a small series, and it's by single surgeon, myself, in 3 cardiac centers in Dammam and National Guard in Jeddah and Moda Hospital in Taif. 2 apical, 2 anterior, and 2 posterior. All of them operated more than 10 days, except one. Except one case. I operated earlier because he started to have he came with renal dysfunction, mild. We waited, it gets higher, so we operated, and this one didn't make it. The other 2, just because we waited, I think so, not because we are good, it made a difference. These are the patient demographics, and these are the result of the patients. One, we lost him due to renal failure. The other, and see, it's the average time to operate was 11 days. Now, why surgery is difficult? Because simply, what they found from analysis of STS database by the person who invented this operation, Dr. David, one of previous teachers in Canada, they found only 0 to 3.7 patients done by 1 cardiac unit. So if you have 8 surgeons, they will never do in 1 unit. So repetition makes surgeon better, but it cannot be applied. The operation is difficult, and it is very rare, the cases, so nobody gets chance to get better at it. When he analyzed Toronto series, he found that if you operate more on them, you get better, and your result improve when he analyzed his report. Again, as I said, the difficulty comes, the second reason for the difficulty is that because of the quality of tissue, it is edematous, necrosed, liquefied, myocardium, and suture doesn't hold, basically doesn't hold. I tell my resident that this is how we stitch butter inside the matchbox. You can see, very hard to stitch and stitch break. And you have to do this less than 100 minutes. Otherwise, the patient will never wake up. This video, just quickly, I'll run it. This shows the anterior VSD. That's what you see in surgery. That's exactly what you see. And through this hole, you have to put your patch and get along. This is This is the exclusion technique invented by Dr. David. This is the bad one. This is the posterior VSD. This is how it looks from outside. Exposure is very complicated and difficult, and barely you can see. These are the two cases I did. It shows you, I put a full head just to demonstrate how big it is. It's a big hole, especially the posterior ones. So we have to put, I didn't use exclusion technique, we use another technique because it doesn't hold. It just doesn't hold. So we have to make like a pediatric VSD repair. So put a patch inside, put a patch outside, 100 minutes, less than 100 minutes, you have to do that and get out quick. Otherwise, you have a problem. And it's big holes, especially the posterior ones are big holes. This one was 4 centimeters. Okay, and again, you have to involve putting more patches. This is the 2 meta-analysis. This is the most recent 2 meta-analysis, one from Japan, comparing the percutaneous with the surgery. One from Japan by Dr. Yamaguchi, and the second one from Dr. Wu in China. They looked into 7 trials. They did meta-analysis. So they get 7 trials, 2 trials, and they compared. And in each trial, they collected the patient number between 600 to 700. It showed no difference in the 30-day mortality. This is 2003, 2004. There is no difference in between surgery and the device. The numbers of 30-day mortality is high, but 34, 38 in one study. The second, the meta-analysis, same thing, 37, 40, 40. So there is no different 30-day mortality in the literature between surgery and device. This is 2003, 2004. The midterm, same thing, midterm, meaning who lived 1.5 to 5 years, no difference again, if you do surgery or device. Okay, just the conclusion. I'll bring the conclusion. Just the conclusion. 1 minute more, 1 minute.
Okay, 1 minute.
1 minute, 1 minute only, 1 minute. Okay. The best survival if you involve the heart team and individualized treatment. There is no one size fits all. The optimal procedure, optimal time of surgery will remain debatable until we have a prospective trial, which I think is impossible. You can't. The STS database states that the transcutaneous technology still underreported and were not done frequently to exceed surgery. So we need to do more and learn more. The surgical closure and the transcatheter closure, they have, this is important, they have a close short-term mortality rates, but higher shunt with the transcutaneous. You can, or better to close if you cannot do surgery or the patient is very high. The device approach is less invasive. It allows immediate closure of the VSD and could act as an alternative or a bridge to surgery, especially if you have multi-organ failure. The device closure has a high technical success rate, low complication rate, but high hospital mortality rate, like surgery. Either way, you go surgery or device, if you operate early, it's not because of the procedure, it is because of the quality of tissue. Even if you put a device, it will fall down. The device closure obviously is good for patch leak or if you have a poor surgical candidate. To improve, don't refer to somebody else. If you do 1 case a year, I advise you don't. Send it to somebody, let him struggle with it, instead of doing 1 case and he will die. Very likely. This is the experience. So better you refer it to one center. By time they will learn, they will get better at it. You help them, they will help the patients. But doing one case a year or every 5 years or 3 years, one case, that doesn't work.
Thank you, Dr. Abdulelah. Great talk.